Thank you so much. Um, I think now all the modules are piggybacking to RAAB, and maybe it is a good idea because we might not be spending as much in each and every model if we go on their own. So if we can piggyback those things to RAAB, maybe that's a good idea. Now Pushkar is also trying to piggyback something to RAAB again, the health systems. Pushkar, please.
Thank you, Dr. Sam. Namaste and good morning once again. Yes, it's about one more module to piggyback with the RAAB system in the longer run. But today I'm going to present about the process and lessons learned during the course of the development of health system module for RAAB. So we might need some more time to piggyback already, but it's on the way. Yeah, so I don't think we did much about RAAB, but so it's a population-based survey to inform planning, and that has been carried out in 85 countries and 390 plus RAAB surveys so far. So historically, RAAB focused on the prevalence of vision impairment, its cause, and service coverage. However, we need to understand the existing service activity to get comprehensive idea about the eye care situation and the health system circumstances so that we can plan things better. So that's the whole background of developing this module. And the journey started from 2022. So we carried out this development in two phases. In the phase one was identification and prioritization of the indicators. So what are the indicators we definitely need to have in the RAAB health system module? That was the idea. And for this, I carried out document review using all the main sources of indicators that are used in the health system, like Vision Atlas, Eye Care Indicator Menu, EXAT, and District Health Information System. I was literally mapping all the indicators. So which indicators applies at the national level and which indicators can go at the sub-national level. So that's the whole idea. And then I carried out virtual interviews with 16 participants from 11 countries. I believe some of you contributed to this. And we were mindful of country context. So we covered small, medium, and large country scenarios when we were choosing participants. Then with the participants, we ranked the indicators from the list of the indicators we mapped out based on the relevance, actionability, ease of data collection, or feasibility in the different country context, and comparability so that we can have some benchmark at the end. And our focus was on the sub-national level planning here. And then in phase two, we pilot tested those indicators and the tool, whether those indicators make sense for the countries and whether to what extent we can get the data for these indicators. We developed the data collection tool and data compilation tools in basic Word and Excel format, and then we piloted the tool. The tool has mainly two components, and that covers a wide range of issues, policy-related data, socio-demographic context of the catchment area, where RAAB will be implemented, and list of the health facilities. And then the team goes to the health facility to collect specific data about service availability, human resource situation, and then three morbidity conditions: cataract service, refractive error services, and diabetic retinopathy. So these are the three conditions prioritized by the interview participants based on the criteria I mentioned. And then we implemented the pilot in 4 country context, one in North India and Malaysia, Kenya, and Burundi. So Burundi is the only country where it was applied nationwide, given the size of the country and number of eye care health facilities available in the country. But in North India, again, it's Dr. Shroff's Charity Hospital's catchment area. In Malaysia, 3 provinces were included, and in Kenya, 1 county was included, and Burundi, all across the country. So in stage 1, local data collection team collected data on policy, socio-demographic, and health facility overview data. And as Jack mentioned, again, it was tailored to the existing RAAB survey going on in the country. So we didn't have a separate team for the data collection, but we tried to fit with the ongoing RAAB survey so that it won't be too expensive to carry out. And then, depending on the data availability, they decided whether they have to go to the health facility to collect human resource data and service specific conditions, or in some conditions like in India and in Malaysia, they communicated, the central team communicated to the district team and then contacted the health workers and they asked to provide the data and they compiled the data at the center. And then at the end of the data collection, I had a joint meeting with all the country teams and to talk about their lessons learned and reflections and what went well and what didn't work well for that. All right. So I'm not going to present any specific finding, the data as such, but it's more about what we learned. So the first thing was, yes, there was gaps in data availability and completeness across the country. Some of the data like policy context, for example, do you have cataract service guideline or not? And are they implemented well? Those type of questions. And do you use ICT code to record eye conditions? Those sort of things, they were available in all the countries. Socioeconomic data, it's pretty much available, although in some context, disaggregated data was challenging, especially urban and rural disaggregated data. And then health facility data, aggregated data were available in most of the settings, but private health facility data were largely not available. Refraction and spectacles unmet need data was also very patchy, and diabetic retinopathy was very rare. So this is an example from Malaysia, for example. You see, these were the number of health facilities the team confirmed these services were available, but only these green bars were the health facilities with data available for these conditions. And there was no data available at all for rehabilitation service. And here are some quotes from the research team. They said, like, one of the biggest finding, and I was quite happy to see that, was they found, understanding no data is also a finding in the research. So when we realize that we don't have data, then we start doing something. So that was very encouraging. And then they said the tool enables evidence-based eye care planning. They said, yes, we get data, big picture from the RAAB survey, prevalence data from the RAAB survey that helps us for the advocacy part, but to do something in our context, we need all the details. And then in one country, they said fixing the DR data gaps already. They said, okay, we had everything, but DR system was not in the place. So we already starting that journey now after this survey. I'm just trying to put that in the context, so how it contributes the overall process. And in the planning, in typical planning process, what happens is, first we need to observe, okay, how big is the problem? And then starts, that's what we get from the RAAB survey. And then we need to understand our system, okay, what is there, what is not there, and what we need to fix it. So these are the questions this RAAB health system module will help to understand for the local team. And so together, RAAB survey and RAAB health system module will help to get the complete picture of the problem and also the solution, and then they can design the improvement program. So that's how it is in the context. There are a few things to be done. So we need to customize the RAAB package, again, to complement it to the broader RAAB methodology. And then, yes, we have been working on just Microsoft Word and MS Excel, which would not help in the long run. So we need digitization of the tool, but we need a few more studies to understand the real situation. That's all. Thank you.
Thank you so much. Yes, there money will be needed, but maybe not double, but 1.5 might do. Thank you, Pushkarji. And any question? Tulsiji, please. Mike.
More seeking a clarification.
Yes, Pushkar, come.
The previous presentation, economics, it was clear to me that it would be an added module to the RAAB survey, where the respondents would be the people in the community.
Yeah.
But in yours, it looked like the respondents were not the people being assessed for eye care, but then
No.
It's
Okay.
health system stakeholder response.
It's completely different respondents. Okay.
Yeah.
Yeah. Yes. So the researchers or the data collectors will go to the health facilities to get the answers.
So it's
Okay.
basically the facility data to complement the RAAB survey data.
Right.
It's more-
Okay. Okay. Thanks. Any? Amanda, is it? No.
Just quickly to understand what is the difference between EXAT and this health systems assessment.
So the simple difference is EXAT is huge. This is the micro version of EXAT, if you like. But it has only the selected indicators that can be practically done, and then that can be updated regularly. And it's more based on the health facilities data, and service data is also covered here. But EXAT, it's really huge.
Yes. Yes, EXAT is big. We just
Yeah.
finished our EXAT of the whole country, and it took quite a while to finish the EXAT. Now it is with the Ministry of Health, and we are waiting for the response from the Ministry of Health. Okay, thank you, Pushkar.